Pleasure to be here with so many leaders, innovators, and partners. As Melody said, my name is Scott Phelps, part of BWXT Medical, Director of New Products and Commercial Operations. Our session today is going to focus on multidisciplinary health approach to scaling Canadian capacity. Whether we work in clinical practice, research, manufacturing, policy, or technology development, we feel the same pressures: growing demand, more complex patient needs, an environment when innovation moves faster than ever. But we have something else in common: the opportunity to reshape how Canada mobilizes its talent, its infrastructure, and its ideas. So I'd like to welcome our panelists and have you each introduce yourself, and then we'll hop into some questions from there.
Thank you, Scott. I'm Fiona Cherryman. I'm the Vice Principal of Academics at the Michener Institute of Education at UHN in Toronto. Thank you.
Thanks, Scott. Narinder Paul. I'm the Chair and Department Head of Medical Imaging at Western. I'm also the Provincial Lead for Medical Imaging and Oncology for Ontario.
Amit Singnurkar. I'm a nuclear medicine physician. I work at Sunnybrook Health Sciences Center. I'm the Division Head of Nuclear Medicine. I'm also the Program Medical Director of Nuclear Oncology at the Cancer Center.
All right, so first question for all the panelists. What are the most urgent workforce gaps limiting the expansion of radiopharmaceutical care in Canada today? And what roles are hardest to recruit and train at scale?
Start with you and then go backwards.
Thanks, Narinder. I knew this was going to happen. I think this is nothing new compared to what we've heard earlier today. But, we saw it coming with the increase in utilization of PET-CT in this province, and we've been kind of flagging this concern for many years, which is the availability of technologists. So these technologists have obviously special functions. They're nuclear energy workers, and so there aren't others that can really fill those gaps. So, just with PET-CT, we were struggling with capacity, and now you add this additional burden of, this opportunity to treat patients with radioligand therapies. And so, that shortage actually becomes more acute. So, certainly nuclear medicine technologists are something that we talk about often. I think we'll also probably, be struggling with nuclear medicine physicians at some point. It takes some time to train these guys and these folks. So, and it's a fairly long training program. So this is something that we also have to kind of apply some thought into, in addition to some specialized program like Dr. Wong was talking about earlier today, where you can train people in specific expertise in radiotheranostics. So I would say those are probably two top of mind right now. Narinder?
That's great. I've probably got a slightly broader spectrum to that. For me, we've heard a lot about innovation, about how Canada has a lot of pieces of the puzzle, but we don't actually have the whole picture. So for me, we're in academic centers, and the research part of it becomes really important, as does the clinical part of it, the education part of it to raise capacity across our country and across other emerging technologies. Then the outcome analysis becomes important. So for me, if I can start with that, the science piece is also a jeopardy. We don't have so many radiochemists. We don't have so many people who are molecular biologists who are in the radiochemistry lab putting these compounds together, working with industry to try these novel techniques out so that we can actually do clinical trials that will lead to implementation into clinical practice. The MRT piece is really, really important, as Amit said. We know across the province there are centers that operate PET-CT now that they can't allow their techs to retire, or at least the techs aren't retiring, because they know if they retired, there'd be no service, right? So we can talk a lot about putting more PET-CTs in, but we have to do it in a mindful way to make sure that those PET-CTs can be operated, right? So nurses, we didn't mention nurses, right? Theranostics, we're using nurses in London. Jonathan Roms and the team have been leading that development. And the other thing I would say, not necessarily in terms of HHR training, but in terms of knowledge, is administration. Because if you sit in my hat and we're having to control the budget, having administrators that know the rationale as to why we're spending a lot of money putting these processes together for a 4-month increase in survival is going to be really important, right? So then it comes to the equipment. I think Patrick mentioned earlier about PET-CT. I should mention, I don't know about the other provinces, but Ontario's done a really good job, I think, in paying for PET-CT machines to go into academic sites or actually cancer hospitals. They don't pay for the renovations, but done a really good job in putting those in. And I think part of that ratio of PET-CT to population is we're a very densely populated province compared to, say, New Brunswick or some others, certainly in the urban areas. So I think it's important to know that there is a program behind that trying to populate these places. So I think, nuclear medicine techs, 100%. But this problem we could have seen 15 years ago. It's nothing new.
I mean, this is nothing new.
Yeah.
Yeah.
And the way that the new radioligand has been implemented, as Amit said, there's not a single nuclear medicine department that I know that had empty slots, that had free time. So when the opportunity came to be able to provide this necessary treatment for our patients, we took that on board, but then we had to let other things go, right? Bone scans or cardiac scans or whatever. Every nuclear medicine department's making a choice. So this is not something that we can sit on and say, well, in 5 years' time, we'll be fine. Like, we're already behind. If we took every single tech that's trained across the country, and there's not many training centers, which Fiona is going to address, we'd still be behind the scene, right? So we have to expand our capacity to train. We have to have more training centers. Ideally, Michener will establish more hubs around the province, but other provincial centers are going to have to do the same because it takes time to build a quality program. So having a new place started up from scratch is probably not sustainable, right? So now that I've set the stage for Fiona to say they're going to build hubs around the province, go.
I did warn you he was a problem child. Thank you, Narinder. So education is a great opportunity to really feed the health human resource gaps that we have in the system, but it isn't a quick solution. So what is the solution that we need? Well, we have our undergraduate programs across the country, but for technologists, there's less than 10 in Canada. So it's not a big marketplace that we have on offer. So what are the other pathways that we can explore? What are the essential care competencies that we need to be able to deliver safe and compassionate care to patients? Can we upskill other healthcare professionals, which is really challenging because many of our professions in the healthcare system are also facing many shortages. So are we robbing Peter to pay Paul, or is it a temporary way? Can we offer some different pathways so that as an employer, as an academic center, I can move my resources, my human resources around so that we can meet the needs as those needs come and go when the funding ebbs and flows? Will we have a more transferable skill set in our technologists? If we look at different models of education, like in Europe, we see the different disciplines where the technologists are choosing to specialize in 2 disciplines. So maybe that's an opportunity for us to explore. In Ontario, our regulatory college, the CMRITO, is actually exploring new pathways and new regulatory ways to move forward. And that may offer us some opportunities to really flex our workforce to meet the different needs that we have. This morning, it was really interesting to hear about delivering care to remote communities. How will that look? Will we be able to really utilize the large academic centers as hubs, as we do for other programming? It may be a real way that we can utilize our resources in inventive ways.
So maybe I could address that, because Amit and I have been co-chairing a provincial radioligand therapy committee with
Narinder, you broke the podium.
What did you do?
I trained in MR, as you can see the influence. So for the last year, we've had, and by the way, I should say, although we talked about nuclear medicine physicians, radioligand therapy also, radiation oncologists, medical oncologists are also involved. So let's not forget that there's probably shortages there too, right? So just want to make sure. So we've had a province-wide committee, working group, I should say, of different disciplines looking at how do we how do we create access closer to home for the patient for these novel therapies, right? And so the document that was mentioned earlier, the Pan-Canadian Quality Radio
The PCQRT.
I'd like to say the whole thing. And you see the difference between a cardiothoracic radiologist and nuclear medicine, very short. So that was sort of helping us to talk about a quality program, starting from 6 hub centers in Ontario, but next phase will be cancer centers that are out from those hubs, so the hub and spoke thing. And then there's a potential third phase to get to smaller centers, just like the talk before the break was talking about community centers. 60% in the US are providing radioligand therapy. I'm not sure if we're going to have the same proportion, but the idea is, as we establish the quality network, as we establish the training, and as we establish, I believe, Rebecca, you were talking about a central MCC access for these patients, but they could be treated closer to home. That is 100% the direction we're trying to go. The key thing to understand, though, is there are certain requirements for a quality program, right? And we have to make sure that the centers that are looking to host these therapies can meet those requirements, because what we don't want to do is drop the quality standards. And I'm pretty confident that we can get there, but it may take time for certain centers to do that. But the idea is certainly not to keep it within the 6 main centers, because we know down the road, as was mentioned, Alzheimer's therapy is coming. There are other cancers, breast, colorectal, et cetera, melanoma. So we won't have the capacity in the system we have now if and when new therapies come.
Well, as you mentioned, it's not just a question about capacity, it's about access close to home, right? So you don't want these folks traveling to a center that's like 100, 150 kilometers away from their home. Because what happens essentially is that some patients will not complete the treatments, or some people will just elect not to have those treatments, when that treatment is the best treatment for them, right? So you want to make it as easy as possible. Remember, these are cancer patients, right? They're sick. They have to take time off work, their families have to transport them, or they have to get medical transportation. So all these things factor in. So our job is to deliver the best care possible to everyone who needs it. And one of the ways in which we can do that is to have care close to home. And that's what we've been working on for the past year or so.
Perfect, thank you. So, Amit, this question is directed at you. To what extent is the lack of standardized radiation safety protocols and discharge criteria slowing down scale-up, and what would national alignment realistically require?
Right, so the radiation safety aspect obviously is a big part of the practice of radioligand therapy. And so I guess just to set the stage, obviously we have a framework, right? We have the Canadian Nuclear Safety Commission, CNSC, and they provide us with framework, with guidance documents that kind of guide our operations. But it's a framework, right? So they do allow flexibility at the site level to see how we actually interpret that framework, and then how we execute that interpretation. And so that's where the variability lies. Right, so I mean, the CNIC themselves, they're quite easy to work with. I've worked with them across several organizations, and they're easy to communicate with, and they're pretty clear in terms of what their instructions are. But it's really at the site level where things can be variable, and this is a problem in medicine in general, right? I mean, you ask 10 doctors, you'll get 10 different answers, and I feel it's similar for RSOs. You'll get a slightly different interpretation, and the problem is that they serve a very important role. But the thing is, if you're too conservative, that reduces your patient flow. How many patients can you treat? Do you have to admit the patient, which is a big deal in a large hospital, right? We don't have any hospital beds. But then again, if you're not careful enough, then you're exposing the public to unnecessary radiation, right? So, I mean, these problems are not new. This has existed for a long time. I mean, for anyone who practices nuclear medicine, which is a lot of people in here, we've been doing I-131 treatments for a long, long, long time. But I think the reason this is becoming more of a concern is that it's just the sheer volume of patients, right? So, you may have a couple of patients walking around the city with I-131 treatment, but now you will have dozens of patients with radioligand therapies, right? So you also want to keep the community doses down. And we've encountered these issues already. So like the more patients you treat, the more things that you encounter. For example, a lot of these patients are sick. So, sick prostate cancer patients, and then they have people who like nursing care at home, they have caregivers, and so how do you limit exposure to these folks? How do you limit exposures to, let's say, so they show up to the emergency room with another problem, right? They often have comorbidities, which means they have other problems other than cancer, so they show up with a heart attack, show up with a stroke, and then how do you manage these patients? So all this education has to happen. So I'm encouraged to hear that there actually is work being done to kind of harmonize how we do this. And this was, I just found out about this today, but I believe Novartis leads a call like every month or so with radiation safety officers. I don't know if you knew this, but across different centers in Canada, where like, I think 60 plus radiation safety officers kind of talk and kind of share notes. There's also the PCQRT folks that are now developing a guidance document as well. I think they're part of the way through the process. So I think this will all help because, I mean, I talk to my RSO pretty much every single week now, maybe a couple times a week, just because we always have kind of new problems that arise or new kind of considerations. And so I think the more guidance that he would have and then other RSOs have across different organizations, we should have some guardrails that define the way in which we practice so that one center is not too restrictive and one center is too permissive, and then you have high community doses.
It's also going to be important to have something like a common core protocol where individual sites may have nuances, like individual territories, individual provinces may have slight difference in the way they do it, as long as they adhere with the guidelines, right, within a certain latitude. Yeah,
I think this would just be, the CNIC kind of provides us with a framework, and then these guidelines would provide us with further guidance. But every center is different, right? You have different considerations. So it would just at least put some guardrails on how you operate, right? So there wouldn't be like wild variations in terms of how people are interpreting the guidance from the CNSC.
Perfect, thank you for that. Question for you, Fiona. We have Canadians training pathways across nuclear medicine, radiopharmacies, medical, physics, and nursing developed in the past. How should Canada rethink training pathways to build a sustainable pipeline of specialists to meet future demands?
There's quite a lot in that question. It really depends what the actual outcomes and competencies are. What is it that we want to do? What are the accreditation requirements? And what are the professional requirements? So if we go back to this morning's conversation about transdisciplinary care, what is it that is foundational to all the professions in caring for these particular patients? And then what is specialized knowledge that is needed for the people who are so intimately involved in the care? These are great opportunities for us to maybe also engage with patients. We heard about the Indigenous communities who are really keen to participate as well in these conversations. But again, what are the essential competencies that we want to ensure that each profession has? And no one profession has a monopoly on a certain competency. And that needs to be something that we are in agreement about. It is the people with the knowledge, the skills, and the aptitudes that are able to deliver care.
I'm going to ask you a question.
Go figure.
So one of the things is we know that people who train closer to home are more likely to take on a course and actually work in the area. This relates also to First Nations, This also relates to hospitals that train techs that come from a different area. For example, in London we train a lot of folks from Hamilton and the GTA. And they love us or not, but they also go back to the GTA. So one of the ideas that we're thinking about, with absolutely no discussion with the training centers, which is not quite true, is there a way, just like we're doing a hub and spoke arrangement for patient treatment, is there a way to have a decentralized training system, which will be hybrid, right? We'll have some remote plus some in-person, where you can actually branch out into the province, into different areas, so that you can attract candidates who can't afford to live in Toronto or various places, but could actually go to the local site. They could do their attachments, clinical placements at local hospitals, so that's like a long-term apprenticeship and an interview, basically, and actually basically be guaranteed jobs at those sites. I know it's a sustainability thing and having to scale up, but I think that's something that I would like to see as an employer, to see if we can get people who are closer to home, because they're likely to stay. Right?
Anything is always possible. It comes down to cost and sustainability. We look at our nuclear medicine departments and our staffing numbers are quite small. Whenever we were talking earlier, Amit and I, about 15, 16 technologists in Sunnybrook, a very large academic center, but they're constantly having somebody needed on casual staff to fill in for parental leaves, long-term sick, upcoming retirements, these types of things. In smaller departments where you only have 3 people, then you can do that. You can have people come in for residentials and managing quality across the different centers is one of the big challenges, and also then the cost that you've got 3 students in one place, 2 students in another. We have an example where we had a relationship with another province who really wanted to keep their technologists within their home province. But they didn't have training capacity within that province. So we were able to deliver didactic, theoretical material through a hybrid distance model, but all of the laboratory work and clinical work was done in that home province. And that was a very successful model with just under 20 students. So anything is possible.
So that's yes, okay.
Almost, yes.
Thank you. So, Amit, what does an effective interdisciplinary care model for radiotheranostics actually look like in practice?
So I think we've talked about the fact that this practice requires multiple disciplines. I mean, from the get-go, I think you have to realize that to be successful. At Sunnybrook, and as with many other organizations, really this capability lives between medical imaging, nuclear medicine, and oncology, right? So I think, and I think we have a pretty good program, and the way we approach it is really like, what is the problem we're trying to solve? The problem we're trying to solve is trying to come through for the patient, right? We're trying to deliver this treatment in time for this patient who's sick, who has this opportunity to get the treatment. If you wait too long, then they're going to be too sick to get it. So that's kind of what drove us. I remember, the approval of Pluvicto, which really kind of lit a fire in us, because now all of a sudden we had these increased volumes, increased demand. We kind of cobbled together senior administrators from medical imaging, from oncology, and we just kind of sat really informally and tried to figure out how to solve this problem. In doing so, and in not really being too like restrictive in terms of who does what, we're trying to solve the problem. The way we look at it is, there are many different ways to solve this, to deliver this on this opportunity, and I think to kind of force yourself to shoehorn this into medical imaging or versus oncology, I think that approach we knew was not going to work for us. We really took a collaborative approach in terms of like, let's think of something new, because this really is a new opportunity. So at Sunnybrook, how we handled it is we created a whole new program. It's called nuclear oncology. That's what we call it. And this really is the holistic care of the patient before treatment, in between treatments, post-treatment. And it's really a model of cancer care, and that's how we approach it there. And so, it really came down to, defining this as part of our organizational structure. So it's a small program, it's just starting, but it really is going to be a pillar, and I think many people in this room realize it's going to be a pillar of cancer care. So you have surgical oncology, med-onc, rad-onc, and you have nuclear oncology, which is growing very quickly. And then when you do that doesn't mean that's only a nuclear medicine physician or a radiation oncologist or a med-onc or whoever else is interested. That's one thing. You need people who are passionate and interested in doing this, right? It's very early. We need a lot of capacity. We need a lot of people that are interested and passionate about doing this. And so when you create a program like that, it really opens the door to anyone participating. Insofar as you are, deliver on the the core competencies, the regulatory stuff in terms of radiation safety, et cetera, then you can have additional people participate and really take ownership and be part of this program. And so I think my partner in crime, Dr. Amit, he's a GU oncologist. We kind of run the program together. He runs a medical advisory committee, and I'm quite proud to say this MAC for nuclear oncology, it includes nuclear medicine, medical oncology, radiation oncology. We have a surgical oncologist there. We have a neurologist who specializes in neuro-oncology. And so, I think we need to realize, the treatments that we're delivering don't cover all these cancer domains, but we're really early in this phase of development. And so all these folks are now gaining exposure. We're talking, and a lot of this is about knowledge transfer. We're selling them on the opportunity of nuclear oncology and radiation and radioligand therapy. So when there is a research trial or when there is a clinical opportunity, we're going to be able to go fast and kind of deliver on this, right? It's all about getting buy-in. It's all about, a lot of this just comes down to the basics, right? It comes down to having the right people, developing the right relationships, and that includes, this is not Zoom calls, this is just like, sitting together, having coffee, going to their office, and taking the time to actually develop these relationships. And once you do that, I think everything else kind of just falls into place. So that's how we approach it, and I think we're doing okay.
We're fortunate across the province that we have many centers where the disciplines work really well together. But you can't predict what's going to happen in 10 years or what's going to happen in other centers. So the team at CCO-OH is putting together a sort of a template. I think Amit mentioned it earlier, that it's like a flowchart. It bases on function. What should happen on the patient's journey? What's the key essentials of what should happen? And then alternatives as to who could deliver that particular part of care, right? So I think that helps the template. Amit's very fortunate. We're very fortunate in London, Toronto, et cetera. Very fortunate that we all get along and it's worked. But it also needs some sort of guideline to say, okay, well, in 10 years' time, if this all changes, here's a guideline, right? To say this is so there's no argument around, as Rebecca says, sometimes follow the money can sort of poison the atmosphere, right? So.
Thank you for that. So next question for Amit and Narinder. How can hospitals and healthcare systems adapt their infrastructure to safely and efficiently deliver radiopharmaceutical therapies at higher volumes?
You want me to try and then you give the right answer? Is that how you do it? Yeah. So, with this opportunity, I think the first thing that you need to do is you need to do an inventory of what you have, right? I think, when it's interesting, when you start actually asking questions about what are capabilities, what are our assets in terms of what rooms can we use, or what's lead shielded, what are the latent kind of capacity in the hospital that we can use. This often isn't well defined, at least that has been my experience, right? So instead of building out new capacity, I think you have to understand, number one, what is it that you have and what can you adapt for these different purposes. So I would say that would be the first one. The other one is to really be kind of embedded in the data. So one of the first things that we did when we started this program is to have a good data dashboard. How many treatments are we actually doing? Because, when I took on this role, nuclear oncology role, no one could tell me. No one could tell me with certainty how many we were doing. So the first thing we did is we put together a data dashboard, and it was wrong many times. And then we had to refine it until we got things right. And now we have correct data. So now that we have the correct data, then you have to kind of anticipate what is your growth trajectory. Right. So what is your opportunity in the future? And that's a tough one to solve, right? Because not only is there the uptake phase, not only at Sunnybrook, but all the centers that we take external referrals. So there's this educational phase that happens in the community where they kind of start understanding these treatments. And so what is that demand that exists currently? And then what are the future opportunities? So we always keep an eye on label expansion. We always keep an eye on what is coming through the research pipeline. It's a little bit easier maybe for our organization to do because we run a lot of the trials, so we kind of know what's coming. But you kind of have to understand what is your growth going to be, because if you're going to build out some new capacity, this often takes many years, in a hospital. So maybe I'll leave it at that. Narinder, you answer the rest of the question.
That's a great answer. Mine's probably a little bit more generic and not as detailed. It's it's going to, with the current system, if we're going to increase capacity of radioligand, then we have to give up something else. And we don't want to give up something else. So we then have to partner with other hospitals who can do this something else, and that we can't do, right? So that's an immediate thing. It's also knowing, as Amit said, that chain, right? When the patient comes in, you're the right patient, appropriate patient, you don't want to waste doses. I would say Novartis has been a really great partner in, if we can't use the dose, they have this network where they can say anybody else, there's a dose going, anybody else can use it, right? So reduce the inefficiency piece. I think when the patient actually comes for imaging, there are some things that we're talking about at OH in terms of making sure the imaging is as efficient as it can be, knowing we haven't got a lot of tech. So can we have the equipment as efficient as it can be? Let's not use an abacus when we need a supercomputer type thing, right? And then I think Patrick mentioned sort of some potential in the future for interim scanning to say, are we using the right doses? It's all about trying to manage the capacity you have now to do more with it. The idea of expanding, I think, is two ways. One, we've talked about expanding out to other centers, a hub and spoke type thing. The HHR is going to limit that, right? Because you can't put a machine in somewhere where there's nobody who can run it. So then the question is, do you double up in some places that currently have capacity and could be more efficient with 2 machines rather than 1 machine? And so I think that's the next 5 years or so, while Fiona gets her hubs and spokes training centers going and we can get more HHR. There is a limit on trying to do 24/7 scanning, right? Because the radioisotope, right, that you need the radioligand is not always available, and you haven't got the HHR. So all of these things are connected to each other.
Perfect. Next question is for all of you. How can cross-center collaboration be strengthened across provinces to share expertise, optimize capacity, and avoid duplication of effort?
You want to take that one?
Definitely done there. Well, I think that the opportunity for collaboration, in our case with education, it's always about finding partners where students and learners can really maximize their learning experiences. It's a great way to showcase to employers, future employees as well. But it is also an opportunity to see how efficiencies in the system can be realized in the future, because it's going to be frontline staff that are going to really inform any improvement processes.
So somebody mentioned earlier about a piece of the cake. I think it was the mayor, wasn't it? Talked about a piece of the cake. I think one of the things we've got to realize, and I think we realize pretty well in the Canadian landscape, is we're not in competition with each other. Right, we're not looking for market share. There's more patients than we could ever possibly want, and our challenge is to meet the demand and actually give our patients the treatment they deserve, as Amit pointed out. So the collaboration piece, the understanding what works well, what doesn't work well piece is part of what we've been doing as part of that provincial group. And I think on the pan-Canadian side, I think there is that conversation also going on in terms of the standardization. So I don't think there's a willingness. I don't think there's an unwillingness. Is there 2 negatives? People are willing to work together and collaborate and learn what's the best practice. The question is, how do we disseminate that in a way that's meaningful and that can also be relevant to individual sites as they come on? So part of the provincial program is that we are developing that education package for centers that want to do radioligand therapy but haven't done it, to have a hub site. So for example, if there are hospitals in the catchment area, so to speak, of Sunnybrook, they'll talk to Amit and they'll come and see how they provide radioligand therapy. They'll say, well, what did you learn? What did you change in the first 6 months of putting this together, so that they can actually take the benefits of those lessons learned and then and take those on rather than having to go through the same journey themselves, right?
Yeah, I think that's correct. So maybe I could just follow up on that. So, when we were kind of wrapping up program, starting up, we reached out to our friends at UHN, we reached out to London Health Sciences, and we asked them, how are you doing this stuff? And there's no reason to reinvent the wheel. If you're doing it right, if you're doing it great, then we'll just adapt that to what our situation is. And so there's that relationship building that's really important. We still talk. We talk at these conferences, we email each other, and we know each other, right? So that's one way, but that's just the sites that are kind of doing it, right? Another question is, our goal is to really expand this and have access close to home. And so one of the things outside this guidance document was to really have these hub sites participate in educating new sites, right? So, at our center, we've already had 2 or 3 sites come in it's technologist, nursing-led, basically with some physicians that really give them a day on how to do this and how to organize your program, how to deliver the treatments. They can actually observe treatments. And so part of it is the education component, but I think the more important part of it is the relationship building with the site. So now that the technologists know each other, they can easily call each other, right? It's not like a cold call, you're just asking someone like a random question. The technologist community is, I think, fantastic because, you all know each other and you have relationships from, Michener and when you've trained and worked together. But I think having that reintroduction to a program and reintroduce yourselves to the technologists that are doing this in existing practice and current practice, that allows you to, just a kind of a social gateway to just pick up the phone and call, like, listen, how are you doing these things? We came to your program, we kind of observed things, but there's one thing that's missing. And we kind of experienced this ourselves. So at PET Steering, which is another provincial program that basically rolls out PET-CT indications, we've been doing oncology imaging for a long time, but then we were rolling out cardiac. And then when I came to Sunnybrook about 6-7 years ago, we weren't doing any cardiac imaging. And so I had done some cardiac imaging before, but we wanted to kind of be a program that was able to do cardiac imaging. And so, it was the Ottawa Heart that was that education site that we sent technologists to. The physicians did some cases with their physicians, and we kind of learned how to read, how they read. And now we're practicing cardiac PET, right? So it's kind of the same idea, and now we have a relationship. So now we know their physicians, we know their technologists, and whenever there's an issue that comes up, we know we can just pick up the phone and they're happy to help. So I think that's part of the way that you kind of disseminate this knowledge. I mean, that's on a provincial level. I don't know how you do it across the country, but at least that's how we do it in Ontario.
One thing, Scott, that Rebecca was kind enough to show a slide. I think the future, given that Canada's a leader in radiotheranostics, I think we've got lots of hospitals and institutions that can actually offer not only to Canadian institutions but emerging economies. So we're creating a global training academy, right? We have all the way from training scientists all the way to physicians. And I think the International Atomic Agency through CNIC have had some conversations about it, and they're very excited about what we're doing. And become an anchor site, meaning we become a mentor site for other centers across the world. I think we'll go on that journey for sure, and if that proves positive, I would look to see other centers do the same thing, right? Because one of the things that I wouldn't say just unique about Canada, but special about Canada is it's not just doing what we do, but actually sharing with the rest of the world. So I think there's a bigger stage that we can play on here, but we've got to be able to sustain our operations first before we sort of reach beyond our borders.
Thank you. So it looks like we've come to the end of our session. So thank you all for your thoughtful input today and thoughtful discussion. So what we've heard reinforces a clear message. Scaling Canadian health capacity will take coordination, creativity, and a willingness to work through traditional boundaries. I appreciate everyone's time and effort today. Look forward to future collaboration.
Thank you.